Hello, everybody. Welcome to the May 2022 meeting for the Disability in Medicine Mutual Mentorship Program. My name is Suchita Rastogi, or you can just call me Suchi, and I'm one of the co-founders of this program. I'm an Indian American woman with short black hair, sunglasses, and a striped blue t-shirt, and there is a sunset image in my background. Our speaker for today is Dr. Neera Jain. She is a postdoctoral research fellow at the University of British Columbia, specifically in the Center for Health Education Scholarship. She has done extensive work using qualitative research methods to document the lived experiences of disabled trainees and practitioners in healthcare. Today, she is going to share some of her research in a presentation entitled Reimagining Medical Education and Practice, an Introduction to CRIP Futurity. Dr. Jain, welcome, and thank you so much for joining us.
Thank you so much to Pete and Ken and Zoe and Dakeen for inviting me to come speak to you all today. My name is Neera Jain. My pronouns are she, her, and I'm a postdoctoral research fellow at the Center for Health Education Scholarship at the University of British Columbia Faculty of Medicine. For those of you who may not be able to see me, I have long brown hair with bangs. I wear tortoiseshell glasses. I have olive skin, and I'm wearing a navy and white striped boat neck top, and my background is blurred. I'm so thrilled to be here this evening, and it's really exciting to see how many people are here and that this space exists. It's something I've longed for, to exist for a long time, working in this space and wishing there was something like this to refer folks to. So it's super exciting that this exists. I think these spaces are so important for so many reasons. I think it's a space to build an understanding of yourself, to gain knowledge and skills and share them with others. Community building, power building, world expanding, all of that can happen in these spaces. And I'm so honored to be asked to share this space with you. I want to acknowledge that that I currently live and work on the traditional, ancestral, and unceded territory of the Musqueam, Squamish, Tsleil-Waututh peoples. Although today I prepared the presentation, I'm unexpectedly in Ottawa, and so I'm currently on the Algonquin Nation. And I'm a grateful uninvited visitor on these lands. Beyond this gesture of land acknowledgement, I want to encourage reflection on how colonization is interlocked with ableism. And therefore, arguably, any work of disability inclusion must also hold an interest in decolonizing and indigenizing projects. And that's something I'd be happy for us to talk about more if folks would like to do that. So Pete has given an overview, so I won't spend time on this today. I'll talk for about 15 minutes and then we'll have time for questions. So today's talk is about dreaming, not troubleshooting. And I can imagine for some people, you're tired and getting through the here and now might feel like all that's possible, and getting the tools to get through the here and now. There's more urgent concerns than dreaming. But I want to suggest that we all deserve to dream, even when, and especially when, things are hard. And this is something we can and perhaps should do with others. When we dream together, we start to build a new agenda, and it takes us further and sustains us. So where are we now with disability inclusion in medicine, and why do I think we need to dream differently? I share a quote from a medical school administrator that I think encapsulates often the best case scenario at some institutions. I think that it is a culture of access for those who are willing or able to claw the door open and say, okay, I'm going to participate. Let's figure this out. You can access the culture, but it's not a culture of access. And we know there are places where this kind of dogged insistence is still not well received. But even at more inclusive schools, this phenomenon is still the norm. Learners and physicians can access the culture of medicine with a lot of time, sacrifice, and compromise, but it's far from a welcoming culture. And why is that? Well, my research proposes that this is because medical education, training, and I would argue medical practice is steeped in the system of ableism that centers, it privileges, it assumes a certain kind of body and mind, and the system is organized around that imagined ideal. These conditions reinforce a constrained vision of a physician as one who is primarily non-disabled, and we could probably attach some other descriptors to what that centered physician looks like, or what kind of life experiences they might have had. And this centering of this constrained vision leaves those figured as disabled to negotiate their inclusion in medical education. They're always working around that norm, trying to approximate it, evaluating what you ask for in relation to this expected norm of a good physician. And this limits how far institutions are willing to go to include disabled people in medicine when the norm that's centered is non-inclusive. We're always pulling against that norm, against that ideal when we do any work of inclusion. And so it's an act of resistance to do inclusion, which means it's not something that happens easily, and it's not something that happens fluidly or holistically.
The audio description for the next slide is 2 cartoons illustrating the difference between equality and equity. Both cartoons contain a tall man, a short girl, and a wheelchair user. Each is attempting to watch a game in a stadium from behind a fence. In the first cartoon, which depicts equality, each person is provided the exact same stool to stand on. With the aid of the stool, the tall man views the game without difficulty. The short girl can peek over the fence top if she stands on her tiptoes, and the wheelchair user's view is completely obstructed because he cannot use the stool at all. In the second cartoon, which depicts equity, all 3 people have an easy view of the match because each is provided the implements they need. The tall man needed no help to see over the fence in the first place, so dispenses with his stool. The short girl uses 2 stools, and the wheelchair user sits on a platform atop a ramp.
So thus far, our inclusion efforts arguably have taken an equity approach, and that's what's called for in disability rights legislation. Institutions recognize disabled people's difference and offer tools or adjustments, we can call them accommodations, to level the playing field of the existing environment. Efforts to advance this work have largely focused on improving access to accommodations. So improving logistics, extending their reach, and improving communications about them, as well as, in some cases, opportunistic universal design efforts. We also see measures to increase representation and support retention, improving admissions practices, expanding individual support services, so things like learning specialists, therapy, wellness, things like that. They're individualized efforts to support individuals to access the existing environment. Now, while these approaches do make a difference, and in fact, the improvements that I outlined are very possible in our current paradigm of medical training, there are limitations to concentrating our efforts only on this work. Responses tend to be compliance-oriented. Institutional actors tend to ask, what do we have to do? In the US, This is highly informed by legal standards, case law, and fear of lawsuits. And this tends to create a ceiling for inclusive action rather than a floor, and promotes an austerity mindset for what is possible. And again, when you have this compliance focus, folks who push against that can be seen as troublemakers. They can be seen as they're not always supported by the institution. This model also tends to treat disabled people, as Tchaikovsky says, as the location of trouble. Change is triggered at the point of the individual rather than recognizing the disabling effects of the environment. And this adds consequence to disclosure in a high performance environment and further disadvantages multiply marginalized students. And ultimately, systemic barriers remain intact. Each student must individually ask for and negotiate changes. It's highly dependent on individuals and institutional memory. And for these reasons, I believe our current approach is insufficient to meaningfully achieve justice.
The audio description for the next slide is cartoon depicting justice. 3 spectators attempt to view a game in a stadium from behind a fence. Rather than using stools to see over the fence, they are breaking the fence down.
A justice-oriented approach requires that we dismantle structural barriers. Scholars suggest that to dismantle ableism, we need to break down the false binary of disabled, non-disabled, and rebuild a system that recognizes the true complexity of humanity and the value therein. Here we ought to take an intersectional and cross-movement approach, recognizing that ableism is intertwined with other systems of power and oppression. And this work of achieving justice is difficult work. But I think too often we dismiss this type of thinking and this type of acting and doing as unrealistic and even impossible. The gains we've achieved thus far have been hard won and already entailed compromise. Can we really afford to think bigger? This is how ableism and other forms of oppression hold their power, by sapping our energy and belief in a different world. And it keeps us within a limited frame of incremental improvement. In developing a pedagogy of possibility, Simon asked, what hopeful imagination might inform the struggle for a better future and assist one to act as if a vision of that which is not yet has already begun to emerge? So for me, I found that hopeful imagination in Professor Alison Kafer's concept of crip futurity. With its origins in queer, Black, feminist, and crip theories, crip futurity is a way of interrogating what we see as possible and imagining otherwise. Kafer invites us to consider how our understandings of disability shape the future, and how these understandings shape disabled people's presence and futures specifically. So Kafer suggests that current visions of the future are often rooted in a curative vision of disability. Within a system of ableism that privileges able-bodiedness, we imagine an ideal future as one without disability, in which disabled people are cured or assimilated. This goal of a future without disability keeps current funding and efforts focused on realizing that goal of eliminating disability rather than addressing disabled people's everyday concerns. With this goal, disability continues to be seen as a failure or threat to the future. A diagnosis or declaration of disability is equated with having no future or an undesirable future. And this notion of disability is interconnected with others that are frequently dreamed out of the future, racialized, queer, and poor people as some examples. And we could probably identify many instances of this curative vision in medicine. One way I've observed it is on the insistence on a real world of medicine where inclusion is impossible or highly limited, something we know that's not true based on the folks in this room. But unfortunately, that vision of the future still lives on. Adopting a politics of crypt futurity resists this dominant understanding of disability and the future. Kafer explains that we must challenge the rhetoric of naturalness and inevitability that currently dominate our visions of the present and future. So the current conditions must not be seen as natural and inevitable consequences of living with disability or the natural and inevitable consequent conditions of studying and practicing medicine. Rather, they must be seen as the consequences of decision-making that have not fully considered or prioritized disability in the structuring of medical education, combined with dominant understandings of disability as inability. So to think with crypt futurity entails imagining the future with disability, a future where disabled people thrive and are integral parts of society. So it's a future in which disability is desired and considered a valued way of being. And we can imagine that future through disability, a future where disabled people's ways of being, doing, and knowing are figured into the way the world works. So we can imagine a disability-centered world, building from disabled people's diverse lived experiences, creative problem solving, and imagining more liberating arrangements. So crypt futurity is really a theoretical tool that opens new horizons of thought to interrogate and develop our current and future practice. It pushes us to think imaginatively about the world we want. So to summarize, crypt futurity illuminates how the futures we imagine depend on and reproduce how we know disability now. Importantly, these notions of the future are built on situated knowledge. How we understand the future will be different depending on, for example, whether we know successful disabled people, whether we think those people are outliers, and what we attribute barriers to. Also, do we believe another world is possible? Do we believe current conditions should and can change? So crypt futurity argues that by reimagining the future through a liberating and disability-centered lens, we change how we act now. We insist on this possibility and push towards it, bringing it into being. So in our breakout group time today, we make space for dreaming, to think with crypt futurity about an ideal vision for the future. And I encourage you to think boldly beyond the constraints of what we believe to be the real world or currently possible or realistic in medicine. So when we move into our breakout groups, we can start thinking with the following prompts. What would medical education, training, and practice look like if it assumed disabled people make excellent physicians? So here we can think about how would things work differently? And this might be in big or small ways. What would work really well for me? What might shift? And what would it feel like? We might consider too, how might this imagined future expand beyond disability? How could it be this inclusive vision, be inclusive of all kinds of people? And then if we have time in our groups, another thing to think about, because I think this exercise of kind of world expanding and world building and imagination, you know, as Kafer says, the future and the present are connected. So if we can vision this future, what can we do? What ought we do now? How can we act as if that future already exists? And how can we create the future here and now. So what kinds of intentional community and spaces do we want to build for ourselves that already enact these kinds of ideals? And we can think about who do we want to work with, build with, and dream with to realize this future that we imagine for ourselves. So I want to close with a quote, again from Alison Kafer, that I hope will carry us into this dreaming space. She says, "In imagining more accessible futures, I'm yearning for an elsewhere, and perhaps an elsewhen, in which disability is understood otherwise, as political, as valuable, as integral." So I invite us to take this time to imagine this elsewhere and elsewhen in medicine and other health science spaces together. So before we move into our groups, we have time for some questions. I also have my email on the slide, which is neera.jane@ubc.ca. And you can reach me there if you'd like to ask questions afterwards.
Audience question number 1, paraphrased. What was always interesting to me about the medical world is that it is already heavily involved with patients. Therefore, in theory, it should be easy for healthcare to transition into a more accessible future. But based on how hospitals are built and how they are run, it's clear that even the patient experience is currently inaccessible. How high is the lip of the bathtub or shower? Can I get to the bathroom without undoing all my monitors? In my mind, from an ecological perspective, we need to refigure out how to practice medicine because there is just so much unnecessary waste. How do you suggest we think about all of this? Where do we start?
What I said was that I think that's a really great question because you're absolutely right. There is a lot to think about and to reimagine. So I think in your groups, starting wherever is great. There's no right or wrong way to do this kind of work. So I think starting with what feels most immediate, most present for you, what comes to mind?
Audience question number 2. I think some of this is driven by economics and capitalism in our society. I also think some of it is driven by the real needs of our patients. And sometimes, as physicians, we do, and maybe often, put our own well-being aside for the, quote, better good of our patients, which is noble, but not necessarily the best thing in the long run. But I think that also feeds into this sense of, you've got to have all your shoulders on and in good shape. One question I would have in sort of thinking about the impact of economics on it, are there any countries or societies that you think do a better job of this? I don't know whether more socialist countries might be able to do a better job of this or whether it's just kind of a mess all around the world.
That's also a great question. I'm asked this frequently, and unfortunately, I don't know of an example of a place where things are working better. One example that I did come across that I thought was an interesting one, if you've ever read about the medical education system, I think it's in the Netherlands. What I learned about that system, and this does not by any means answer all of the issues that we might be interested in, but they have a very different sense of time in medical education, where folks move, often have children, they take time off, they do different things in the course of their initial MD training. And what that means is that when somebody a residency program looks at somebody's time to graduation, it's already this really complex equation of what students have been doing while they've been in that MD training. And so it's a different understanding of what that piece of training looks like. And I guess for me, what's interesting about that is the things that are seen as red flags or risk factors, that learners that I talk to are often concerned about, they disappear in a different kind of system. So I guess while I don't know of a health system that is, anti-ableist and fantastic, that I can point to, unfortunately, ableism exists worldwide. But it's interesting to think about how different systems, sometimes they have different problems, but they have things that we think of as problems in a US system are not a problem elsewhere, because we think about things differently elsewhere.
Audience question number 3, paraphrased and summarized. It's not so much a question, but just a comment. I think there are 2 obstacles to disability inclusion in medicine that people generally don't understand. The first one is that people really don't understand what accommodations mean. Sometimes it's just a ramp, a wider walkway, more time, etc. But sometimes it's not that simple. Some disabilities manifest in ways where the accommodation requires more nuance, and sometimes it's not just about supporting a person in their job with accommodations. Sometimes an acquired disability can make somebody unable to do their former job, and in that case, the question should be about how to repurpose that individual so that they are still doing something towards their former profession, even if they can't contribute in exactly the same way as before. The second thing that I think people don't understand is that lack of disability inclusion is a problem in medicine. People with disabilities who have made it in medicine are more the exception than the rule, but the public doesn't see that. When they see disabled people who have made it to the top, they conclude that the reason why other disabled people haven't is that they weren't smart enough.
I think you bring up really good points and really complex points that I think are worth discussing further and thinking about, okay, if those are the kind of big issues that you're seeing, what would be a system that would work better? Or what would people need to know for the system to work better? So that's something we can talk about in the groups.
Audience question number 4, summarized and paraphrased. A local group of legislators in my state put forward a very good pro-disability bill to protect and advocate for university students with chronic illness, because some studies have come out that people with chronic illness don't graduate at a particularly high rate. But the bill didn't pass into law. I heard that behind the scenes, my university's lobbyists were among the parties that opposed the bill. Additionally, my disabled classmates and I have been dreaming. We put together a list of demands of things we would like to see in the university, but the provost's office is basically trying to find a slow way to say no to everything we proposed. My university is fighting the exact type of policies that the federal government and state legislature across the country are putting forward to make university spaces more inclusive. So why do you think universities are the place to dream of a disability-inclusive future? Because that is not what I'm seeing. What I'm seeing is that universities are places where, just to walk in, you have to have armor and friends.
Absolutely. I mean, the reason I'm talking about universities and medical education is because of that's the space that I work in. And for the exact reasons that you're saying, that you're not seeing what you'd like to be seeing within universities, I think universities need to change. But I do think that, there's probably a fair amount of work to do kind of parallel to a university, or in spaces that exist outside of universities. But this is the space that I'm speaking to today.
Okay.
But I think you're right. There are definitely issues. Academic ableism is a major problem that needs to shift.
Audience question number 5, summarized and paraphrased. You started your talk by saying that this is about dreaming, not troubleshooting, and your points are very much about a pedagogy of possibility. But even in this self-selected group, from everyone's comments so far, it seems almost like we are so traumatized from our terrible experiences in this system and in our training that we're not in a space to be dreaming bigger. Instead, we're working on the edges of our survival mode, scrambling and fighting for scraps. It's heartbreaking and highlights the issue. But also, if the next step is dreaming about possibility, then how do we get out of our trauma space to have the capacity to be creative in the way that Crip Futurity really requires?
I think I love that reflection because I think it's real. And even as someone who doesn't live with a disability and who has worked as a disability service person trying to change the system, I think folks on that side of the table are also scrambling and trying to get their institutions, some of them, maybe not all of them, to get institutions to change. And so even when I talk to folks in that space who arguably have power to change things, I think there's similar concerns. So I don't know that I have the right answer for you. I don't know if there was a question for me to answer there. I don't think I'm the right person to answer that. But I think part of kind of talking about that tension is part of how we potentially heal and hold space for kind of holding more than one thing at once and trying to make space for it, maybe trying to intentionally make space to dream, because I think you said it exactly, that if we're stuck in the trauma space of trying to get the bare minimum, we're not dreaming and we're not getting what we really need. So I think that's something that we can reflect on in small groups as well.
I can explain my rationale for including this session to address your point, which I think is well expressed and absolutely valid, is that I keep coming back to this same question of like, what's going to work to like on a national level, on like a global level, to make it so that we can stop talking about this stuff eventually and just be in our space and have, and I come, you go from like a really compliance based approach to even above that, you have a spirit of the law approach. And even that is inadequate. And Nira wrote a chapter about a transformational approach to medicine. And I think that that's really the only thing that's going to like ensure our place in medicine. But nobody can tell me what that exactly looks like, other than saying, universal design and assuming that disabled people are going to be there. And so I wanted to bring somebody forward thinking into our program and use like the collective brain power of this group to maybe come up with some goals that we can work on in the meantime, while we're mentoring each other through the morass of crap that is disability accommodations or disability in American medical schools and practice. So that was my thinking.
Can I add to that, Pete? Because I think that thing of nobody can tell me what that looks like. It's because we don't know yet what that looks like. And it's, I think, something that we need to decide what that looks like, what a better world looks like, because we know it doesn't exist yet. And I think that's the thing for me, you know, when I was doing my research, and I thought what I would find was that kind of spirit of the law approach made things all better, and people were happy and they were getting what they needed, and it was easier and it was great. And what I heard from students was, it ain't enough. It's not enough. And so I was sitting with that, and, you know, I was hearing from school officials that were saying, you know, we're doing all these great things and we've made so many improvements. And what I was hearing from students was like, we're still struggling, and we're still doing that work of negotiation. And I heard school officials saying that too, even though they would say we're doing a lot better. And so when I was sitting with that, I thought, gosh, how do we get beyond this? What is it that we're working towards? And for me, Crip Futurity kind of, it's a force to get beyond that here and now, and to say, what else? What could it look like? How could medicine be different? And I think, you know, I didn't answer question earlier about economics. And I think, yes, the capitalist system is absolutely at the center of a lot of this. It drives ableism. And yet, systems can work differently. These are not systems that came out of nowhere. They're not, things aren't the way they are because they have to be that way. It's because we've chosen or made them that way. And I think pushing back on that, I'm aware that this sounds very idealistic, but I think when we're thinking about what's the future that we want, we have to think beyond these systems, because we know they're not working, and they're not working really for anyone, which is part of the problem.
That reminds me of hearing in workshops I've been in with people of color that the system isn't broken, it was built that way. And it was built to not be accessible to many, many people.
Audience question number 6, summarized and paraphrased. I'm a resident struggling to secure necessary accommodations at an institution that doesn't give many disability protections. When I asked for personal accommodations, my institution said that the task I needed accommodations for was an essential function, and that they could not give me special treatment compared to other residents, even though other residency programs do grant this accommodation to trainees. They also did not consider my condition to be an actual disability. They said that I could either continue working and training without accommodations or leave and find another residency. How can I troubleshoot this situation and advocate for myself to this type of administration?
Yeah, that sounds really challenging. I mean, I'm glad to hear that you have an attorney working with you. And it sounds like you're doing all the right things that I would have recommended that you be doing, having legal counsel, all of those things, contacting Jan, doing that kind of stuff. So I'm not sure that I have troubleshooting tips for you in this forum. I'm really sorry to say that, because I know it sounds like a really challenging space to be in.
Audience comment number 7, summarized. Our system tries to attract physicians who come from diverse populations or who have special talents and experiences, But once they matriculate, the system does little to retain them. Disability is one of many issues that need flexibility. Others might include family emergencies or caring for a small child. The system is so rigid that we don't make changes or exceptions for anyone. As a result, we're all hitting walls. If there were a way to ally with others who want to change the system, then maybe we would feel more positive about dreaming and not so frustrated with the status quo.
It's a system built for a certain kind of person. I'm not even sure that that person exists, and yet the system seeks out people, as you say, with all kinds of life experiences and talents, and professes that is valuable to medicine and to the system, and yet doesn't actually recognize that in the way things work, exactly as you're saying. And I think that idea of allyship, of working in solidarity with other folks who are also running into these barriers in the system, is absolutely the kind of work that could be really valuable.
Audience comment number 8, summarized. We're so used to being there with our bowls, begging for a little more porridge. You are pushing us to dream bigger, to be expansive, and think about how things would be in a world that was really good for us. I think such a world wouldn't just be good for people with disabilities, it would be better for everyone. Thank you for shaking our minds up in a good way. Audience comment number 9. I think we need accomplices, not allies, and that's something I've heard in other contexts. And I think it's really relevant because we need people who are willing to give up their own power in order to improve things for others, as opposed to just getting a gold star for doing the basic human thing. And so I think if there are opportunities for people to advocate for structural change, that's the way to go. And I think one of the ways we do that is by shepherding each other through these processes in order to get people through the things that are difficult, in order to access accommodations for testing or other things where just knowing what the process is and having someone support you through might benefit people.
I love that. I think it makes me think of Stacy Milburn talked about, I forget if she called them CRIP doulas or disability doulas, but that idea of shepherding and accomplices. I like both of those ideas for how we do what we want to do.
Audience comment number 10. If we are willing to go the next step and be an accomplice and really put some skin in the game, put privilege on the line, that's really where these imaginings or the things that we are trying to dream up and envision, that's when you really start seeing it translate into meaningful action. I'm going to take that into my interactions in most spaces. Last week, I got a call from the Chief Fellows about a trainee who came to a head with the attending because they wanted to scope in a particular way that felt right for them ergonomically. That trainee basically had to scrub out and walk out, and the program was looking at it sort of like, that's very disrespectful, right? But thinking about it from her perspective in particular, that's a situation in which the hierarchy and power at play was not willing to respect the accommodations they needed, and those accommodations were not such that they were going to jeopardize patient care or anything. So this, in real time, my being an accomplice, is really going to inspire in that situation and hopefully kick up enough funds for us to revisit how we talk about ergonomics and how we talk about and give feedback in the procedure suite.
I was having the hardest time with physics, even though I could do it. And what someone who had majored in physics said to me was, you have to learn to think physics. And I recently had a historian say the same thing when I was taking a history class for the first time. And even though I had done math and all sorts of science, like a bunch of chem, I hadn't thought in physics, and it was hard. And now I've done a bunch of social science. I hadn't thought in social science, in history, and it's a completely different way of thinking. And so I think that part of, just from watching the conversation, I feel like part of it is that it took me reading like a bunch of disability studies and advocates and activists and stuff, and reading Alison Kafer's book like twice to be able to really get this. So, I think that's part of the like, I don't want to say disconnect, but the sort of chafing that maybe people are feeling.
Audience comment number 11, summarized. The narratives in history omit the experiences and contributions of disabled people. Gouverneur Morris, a huge architect for the Constitution, was disabled. Why isn't there a Morris Hall? Why aren't there statues of him with one leg? Why isn't the history of medicine and eugenics in the 20th century talked about? Why are halls still named after eugenicists like Oliver Wendell Holmes? Why aren't there memorials to disabled people who were subjected to medical experiments without consent, or to the thousands of people who were sterilized because they had a disability? I think if you go back and you change the conversation, you change the stories, and then you can start imagining spaces in the spirit of crip futurity.
Is there anyone else who'd like to share from another breakout group?
I'd be willing to share a few concrete things that our breakout group mentioned in sort of dreaming of a better medical system. We talked about imagining a system where everyone was treated with kindness and allowed to, or given space to be ill, for example, or to need time off for things. A system where redundancy was built in so that having staffing issues wouldn't be an issue. The system as it is kind of depends on a few people, and if one person leaves, then everything sort of breaks, and it doesn't have to be that way. So building a system with redundancy so that one absence won't wreck everything was one concrete thing we mentioned. And representation, which is something that we're trying to do and is part and parcel of why this group exists, also came up in our conversation. And an ideal system would be one where disabilities of different types of disability were represented so that patients with those same disabilities could look up to somebody and say, oh, well, my doctor was able to make it and become a doctor, so that's possible for me too. And then a final thing that was, I think it broadens the scope to beyond medicine, but is still super important. We talked about the kind of privilege that you need in order to even make it to a session like this. And those of us who are in this audience right now, we've had many things going for us that allowed us to get to medical practice in the first place. And so a kind and inclusive system would also be one where we're doing outreach and making it possible and dismantling barriers that come before even setting foot into medical school. So those were a few of the points that our group talked about.
Great, Suchi, thank you. I love all those ideas, and I love the anti-capitalist thread happening in the chat.
Audience comment number 12, summarized. The things that are said versus actually done within the medical system are really hypocritical. Like medicine says sleep is good for you and you need enough of it to do surgery, right? But we are still not giving surgeons or any other healthcare practitioners enough time to sleep, even if it is more dangerous. Resource scarcity also precludes holistic healthcare. Doctors don't have time to familiarize themselves with their patients' charts, and some family health clinics instruct patients to mention only 2 issues to their doctor. This leaves the patient to prioritize their most important health concerns, but that should be the doctor's job. This situation contributes to access problems, a lack of proper diagnosis, and kicking things down the road, because medicine isn't that simple. People don't just come to clinic with 2 issues that you can just put a Band-Aid on and then send them home. A system like that isn't holistic whatsoever.